I'm Dr. Michael Delman. I'm the president of the New York chapter of the American Society of Addiction Medicine and the medical director out at Seafield. I'm going to introduce Dr. Rosenthal. I have a little biography blurb on him, which of course is on the slide presentation that we can't access any longer. So I can tell you that he's got a couple of degrees in addition to his MD degree. He's the editor of the Principles of Addiction Medicine, which is the 6th edition. It just came out within the last 6 months. It's the Bible of Addiction Medicine, published by the American Society of Addiction Medicine. So without further, and he's now the chief of addiction psychiatry at Stony Brook University. And I'll let him do the rest. Dr. Rosenthal.
Good morning. I can sort of see in here, but it's not great. So I'll be turning away from you a little bit from time to time to just see what I'm talking about. Let me tell you about this new car. No. Okay, so we're going to talk today about cannabis, what we know, what we don't. That pothead there, that's a lovely little metaphor. I stole from something that showed up in my inbox, which was a pitch from, I think, Motley Fool trying to sell me stock tips or something. And there was some new cannabis stock or something to invest in. And I said, that's really great. I'm going to take that. So I did. So we're going to talk about macro, big view. You know, New York State's been wrestling with the idea of legalizing recreational cannabis. It has medical marijuana, you know, up and running for a number of years now. Lots of other states have done this similar wrestling job. Some still only have medical cannabis. Others have legalized, as you well know. So we're going to talk about the epidemiology. We're going to talk about, well, what are the harms? What do we know that cannabis sort of brings to the table in terms of risk at a population and a personal human level? Then we can think about, well, you know, cannabis has, you know, 100 different active ingredients in it when you think about the plant itself. And, you know, delta-9 THC, which is the psychotropic, psychoactive stuff that people use it for generally, is only one chemical that's in there. And there's probably a whole lot of other chemicals that actually may have benefit ultimately as medicines because it's been used for a very long time. So we'll talk a bit about cannabis as treatment, but then we're going to talk about the flip side, which is, well, what about cannabis use disorder, people who've been using it and have gotten into trouble with their use and have developed a diagnosable disorder. And then talk a bit about some policy issues that come up in the context of that. There's maybe a way of framing how to think about it, and we have a model legislation that I'm going to present as well, just a couple of pieces of it. So maybe to help the state in its deliberations if the next time it comes around, which it most certainly will. So the epidemiology. Cannabis is, the records go back approximately 12,000 years in terms of archaeologic evidence that it's been around. It probably originated in Central Asia, was grown in Southeast Asia and India. Earliest record of medicinal use is 2700 BC. It's a long time ago, right? Ancient China used cannabis to treat constipation, malaria, rheumatic pain, and female disorders, right? But they also used it commercially in the sense of functional utility as it is used today. Hemp is a fiber, and that fiber can be woven into rope and makes a fairly decent rope. So it was used for making clothes and rope in ancient Greece and China. In India, they discovered the euphoric properties. At least that was the first time we thought that that was actually documented about 2000 BC. In the United States, in the Americas, where the conquistadors came and the English settlers in the 1600s, they brought cannabis with them. They brought hemp, and the hemp was cultivated for fiber early in our history. It was finally listed as a medication in the U.S. Pharmacopoeia since 1850 until it was outlawed and withdrawn in 1942. Recreational use for its euphorogenic properties surged in the 1930s, but the medical use was abolished in 1937 due to Harry Anslinger and his group with the Marijuana Tax Act. So it didn't actually make it illegal. It basically said, you know, you can't do this unless you pay this tax. If you pay this tax, we'll throw you in jail. So it wasn't fun. So when you think about illicit drugs, you know, most of our focus of late, because of the death toll, right, has been focused on opioids. But when you look at the actual prevalence rate in terms of, you know, who's using cannabis products for its euphorogenic properties and other properties, you have about, this is from the National Survey of Drug Use and Health, 2017 data, you have about 41 million people that use the drug in the past year, okay? So fairly substantial number of people, right? And it makes all the other, you know, abuse of, you know, in terms of by numbers, prescription opioids, sedative, tranquilizers, psychotropics, and psychotherapeutic drugs that are used for non-medical purposes, and then all the illicit drugs, which are much smaller numbers of people, although clearly some of those have outsized impairment and death effects compared to, say, cannabis, right? People don't typically die from using cannabis, right? So it's a lot of people. This is from Monitoring the Future, looking at 8th, 10th, and 12th graders. So the green is in, yeah, there it is. So the green is 8th, 10th, and 12th grade. People who've, you know, graders who've used cannabis over the last 12 months. It's, you know, it's come down a bit, it's fluctuated. Obviously the 12th graders are more steady, but the lower grades have come down a little bit. Past year use. However, there is, I believe, a public impact of the legalization and the medical marijuana process. And when you ask these grade schoolers, what is the risk of using cannabis, you see the great risk determination, and it's, you know, obviously the older folks see less risk, the younger folks see a higher risk, but in all cases it's diminishing over time. So as you get recreational use, and in the 33 states that have medical marijuana, right, the meta message to the public is, it's not so dangerous, right? And it's not like going out and buying an OxyContin on the street and taking it and dying because it's fentanyl, right? It's a different relationship. And so the threat has gone down, right? And that's going to have implications in terms of kids' relationship with whether they try it or not, right? Because if it's really scary, most people aren't going to do it, except the most, you know, kind of either, you know, peer pressured or non-risk avoidant, you know, people who are impulsive and thrill seeking and stuff like that, who typically get into trouble before their peers anyway. So current use concerns, this again is vaping. Vaping has now increased, and kids who are using cannabis. You've got 10% of 12th graders, 8% of 10th graders, 3% of 8th graders have vaped cannabis in the last year. And that's troubling, okay? And I'll talk about that in a little while in terms of the harms and what the concerns are. You know, what I told my kids when they were growing up and all their friends were smoking pot was, you will not be socially extricated, but here are the literature. I used to give them these scientific articles and say, look, we know fairly clearly that if you drink a lot of alcohol or you smoke a lot of pot, you know, in your mid-teen years, it's going to have an effect on your brain that may be permanent because your brain's not done yet. Okay, your brain's still cooking, and you're not going to be done myelinating your brain until your mid-20s. So, you know, once you're an adult, you can do what the hell you want because it's your life, you know, and I'm not going to say what you shouldn't do. That's up to you. But if you do this now, you may regret it later because your brain's not done. You're literally affecting the development of your own brain, and that may be lifetime. And we know, and I would say, like, you know, we know the studies showing, you know, heavy alcohol use or cannabis use in the teens increases the rate of substance use disorder development in the late 20s, but also anxiety disorders and depression and stuff like that, which are all, at the very least, impairing. So why burden yourself, right? So this is troubling. These are troubling data, right? And you know, cigarettes, which used to be really big 20 years ago, fortunately has really fallen down a great deal. So the public has really gotten sophisticated around tobacco. Of course, now they're starting to vape tobacco and not smoke tobacco cigarettes, but nonetheless, it's now crossed. We have more kids in terms of daily use of cannabis has gotten larger than the daily use of cigarettes in 12th grade kids. So that's problematic. So this is again the National Drug Use and Health Survey for 2017, comparing it as a look back to 2002. The things with the pluses on them means that that's statistically different from the 2017 data, right? And what you see here is that overall, right, more people are starting to use cannabis than ever before amongst the US population. So legalization, and I can't make a causal attribution because we don't have the way to statistically demonstrate that, but it's likely, right, that all the legalization has actually increased the number of users, right? So more people are trying it because it's legal, right? And that's not a big surprise. What's more problematic about it is when you look at that increase, most of it, in terms of its slope, is young adults, right? Here's the group, 18 to 25 years of age, we're humming along, going a little increase, and then suddenly in the last year, it started to take off, okay? And there's also an increase in older folks, people that are not young adults, but are 26 and up, which means there's new onset of cannabis use in folks who never tried it before as adults, right? Meaning 50-year-olds, right? And 40-year-olds who probably, because it was illegal, may have never really tried it before. Again, there's the slope. 18 to 25-year-old folks are really the group that's accelerating. But as I stated, also in folks 26 years of age and older, that's a problem. That's, past month use. Now, we look at those young adults. I showed you the past month use, and it's going up considerably year to year from 2015 to 2017. Pretty consistent increase. I think it's related to legalization. But here's the kicker, is that it's also increasing the proportion of folks that use daily. And that's really risky, because when you start using a drug daily, you're increasing your risk of developing a disorder, right? If you smoke pot once a week, odds are you're not going to develop a disorder. Young adults, and here's where it starts to get interesting, right? So, I've already said past month use in 18 to 25-year-olds has been going up, but where it's statistically significant and seems to have a larger arc is in women. And that's new. That's new because epidemiology of substance use disorders in the United States has always been men have double the prevalence rates for just about any use disorder than women. Women have double the rates of anxiety and mood disorders. Men have double the rates of alcohol and other substance use disorders. Year to year to year, going back to 1980, from the ECA study forward, okay? But that's starting to change. Women of the 21st century are different. You look at the opioid epidemic and you look at prescription pain pills, we're seeing the same thing. Women are overrepresented in a way that we've never seen before. And it's similar with cannabis use. So we're seeing an abrupt rise in women. And this is, young women, 18 to 25. 14% increase over the last 2 years. Older folks, 26 and older, they're babies to me. Past month use is going up, right? But past year daily use is also going up, not at the same rate, but it's still going up. And again, I believe this is the exposure problem, right? Anybody older than 12 having a cannabis use disorder? So now we're focusing down. We've gone from initiation to any past year use, to past month use, to daily use. And now we're talking about people who have the disorder, who make the criteria. It's highest in young adults, right? They're using the most, and they're showing the most impairment. Not a surprise, right? But I talked about this rise amongst women. So there's a wrinkle. Women get pregnant, right? So we've seen in women in general a statistically significant rise over the last 2 years, from 2015 to 2017. Look what it's happened. Look at the slope among pregnant women. Pregnant women are using cannabis at rates we've never seen before. They don't know the risks, they don't know the harms, and that's a problem. It's more than doubled over 2 years. So what are the take-home findings here? Cannabis use is increasing among adults. The greatest increase is seen amongst women 18 to 25 years of age. Significant increases in daily or almost daily cannabis use among adults, and more pregnant women using cannabis with significant increases in daily or near daily use. Okay? So this is something brewing, right, that we're going to need to address at a population level. So what's happened to cannabis? It's evolved, right? There's business now. It's evolved. Delivery systems have evolved, right? Over the last 20, 25 years, growing has evolved to more potent strains, and strains for being grown for particular characteristics, particular balances between THC and cannabidiol, all kinds of stuff, right? So you can use it you can get into your body lots of different ways, right? You can smoke it, which is the traditional thing. You can eat it. You can drink an extract. You can inhale it, like vapor. You know, the Sinsemilla, which is the flowering tops of unfertilized female plants, runs between 7 and 14% on average of tetrahydrocannabinol, right? But now there are these extracts, which is not the thing itself, not the plant anymore, but some sort of process, whether it's water or an organic solvent, that pulls the THC and the other terpenes and other cannabinoids out of the plant and puts it into a different format, right? And so the ooziest format is hash oil or honey oil, and that can have anywhere between 15 and 50% THC content. Pretty powerful stuff compared to the stuff that people were smoking when I went to college, okay? It's like a different drug, right? Then there's wax or butter, which is it's like lip balm. It's got a waxy consistency to it, and that runs upwards of 70% THC. And finally have shatter, which is probably the purest extract that's sort of, quote, commercially available, okay? And that's a hard resin solubilized with THC, with butane, and that can be 90% pure THC. So when people are taking a couple of hits of that from a vape, that's a whole different experience than someone taking a puff on a joint in 1971, okay? It's a very, very different reality. Very different experience, right? So what does cannabis do? It acts on two major receptors in the brain and body, the cannabinoid 1 receptor and the cannabinoid 2, CB2 and CB1, right? And there are other receptors that have been identified, but they're less well characterized in terms of their function. You know all this stuff: heightened sensory perception, euphoria, followed by drowsiness and relaxation. There is impairment in short-term memory, right? Attention and judgment, impaired coordination and balance, which is why you should not get stoned and drive. It's dangerous because people overestimate their capacity to be both responsive and to make the right decision when stuff happens. Like, everything's fine when stuff doesn't happen, other than maybe you end up someplace other than you intended to go, right? But what's the problem is when the ball rolls out in front and the kid's following it, okay? And there's somebody on both lanes on each side of you. Now what do you do, right? Those kinds of rapid decisional processes where you need all of your cognitive power, all of your attentional power locked into an emergency situation that you have literally seconds to make a call, right? And your cognitive functioning is impaired by cannabis, right? Long term, you get cannabis use disorder. There may be permanent cognitive problems. Also, all the medical stuff for people that smoke it, all the bronchitis and possible lung and upper airway cancers. When you drink on top of it, it magnifies the increased heart rate and effect on your blood pressure, intensifies your cognitive impairment because it's synergistically impairing your brain's function. I'm going to talk about withdrawal in a little while because when I was growing up, there was no such thing as cannabis withdrawal. Nobody knew about it, and that's one of the reasons everybody thought it was safe, because it wasn't really addictive because there was no withdrawal syndrome. Okay? We know that today to be absolutely false. Okay? It's false. Okay? It's just that the cannabis then wasn't potent enough for most people to have those kinds of symptoms, and so it wasn't really recognized operationally. It has been. So increased potency, the cannabis has been, potency has been increasing over decades. Higher level exposure may explain the increased emergency room visits we've been seeing regarding cannabis use. For example, there's all of these edible formulations, and people eat them. And then, after a half an hour, they don't feel anything. So they figure they haven't eaten enough because they're used to vaping or, smoking or whatever else. So they eat more. And maybe even 15 to 20 minutes after that, they eat more because nothing's happening. And now they're starting to get angry, right? And then at about an hour, they start feeling something and they kind of go, oh, okay, this is fine, right? And another half hour into that, and they're starting to get disoriented. And 2.5 hours later, they don't know where they are. They may be hallucinating because what they've done is they've just unintentionally overdosed. And this is what you see in emergency rooms, not infrequently. People in a psychotic or delusional, otherwise delusional state, agitated, freaked out, panicking, because they're in a state of intensive exposure to tetrahydrocannabinol. Okay, that was unintended, right? Higher THC levels may also increase risk for cannabis use disorder if people are regularly exposed to high doses, meaning if they're daily users. It's just like anything else. A little bit your brain can handle. A lot of it your brain has more difficulty handling. And a lot every day, your brain changes to handle that load. The brain is a miraculously adaptive organ, okay? But it doesn't adapt without a cost, right? I mean, you're all familiar with alcohol. When you become tolerant of alcohol and then you stop, stuff happens. And that's because your body's basically twisted itself into a configuration to adapt to having alcohol on board all that time. And when you stop, all of that is now unopposed by the alcohol, and your brain's in trouble. So let's talk about the harms. The National Academies of Sciences, Engineering, and Medicine released a work group document in 2017 called The Health Effects of Cannabis and Cannabinoids. And what they did is they really reviewed all of the scientific evidence about what cannabis could or couldn't do based on all of the extant research, right? And they then gave all of the studies that they examined various attributions in terms of the level of evidence. Whether it's substantial evidence, whether there's some evidence, whether there's weak or no evidence, right? And so what we do know is that there's a statistical association between cannabis smoking and worse respiratory symptoms and frequent chronic bronchitis episodes from long-term cannabis smoking, increased risk of motor vehicle crashes, lower weight of offspring when pregnant women are smoking, right? And development of psychoses like schizophrenia with the highest risk among the most frequent users. For decades, we've looked at and known about the association of adolescent cannabis smoking and onset of schizophrenia. And both the negative and the positive symptoms start earlier in the trajectory of course of illness when kids are smoking pot, right? But for years, all we could do was make an association, right? Finally, in one large study, interesting enough, the senior author's name is Large, that they had a large enough N, a large enough number of respondents in the study that they were able to do sophisticated statistical analyses and found a causal attribution. And what they found is something that is going to sound strange to you, but is real. It's called bidirectional causality. So that if you have schizophrenia, and we've known this from epidemiology for a long time, it increases your risk for having a cannabis use disorder. Conversely, if you smoke a lot of pot, it increases your risk for the development of schizophrenia. And both of those associations are now deemed to be causal. So pot can cause a psychosis, and a lot of times that psychosis is not self-limited, but will either trigger off a latent genetic vulnerability for the development of the disorder. Okay? And conversely, having those disorders tends to generate risk for maybe self-medicating or other with substances, including cannabis. There's substantial evidence that stimulant treatment of attention deficit disorder during adolescence is not a risk factor for the development of cannabis use disorder. That's good news. You know, I'm not going to get into all the stuff about misuse of stimulants, of which there's plenty. But with bona fide ADHD, if you treat it during the adolescent years, it actually reduces risk for substance use disorder, interestingly enough, because people think better, right? Being male and smoking cigarettes are risk factors for progression of cannabis use to problem cannabis use. Inhaling cannabis use, initiating cannabis use at an earlier age is a risk factor to the development of problem cannabis use, and I'll show you a slide on that later. There's also a statistical association that's substantial that increases in use frequency is highly associated with progression to problem cannabis use. In other words, like I said, if you smoke daily, you're much more likely to develop a use disorder. It's common sense, but it's now supported by scientific evidence, right? Being male and the severity of problem cannabis use, so men have higher risk. Now that's a more traditional finding. As I said, men are at higher risk than women for the development of substance use disorders in general, and cannabis is no different in general, right? So 9 to 17% of users develop a use disorder, and 30 to 50% of daily users, especially if you start early. If you start smoking or using cannabis products before age 18, it much increases the likelihood, right? Like I said, a single episode of use can cause a transient psychosis, but it may also trigger a more profound disorder if that latency is already there, right? There's especially high risk for edibles, high-potency cannabis, or products like concentrates, which have higher THC to cannabidiol ratios. So it seems to be that cannabidiol puts the brakes on the psychotogenic effects of THC. So people have less in the way of psychosis, they have less anxiety, they may be less likely to have a panic in the midst of intoxication if there's a higher cannabidiol content. And that's so much so that that's now being investigated legitimately in research, NIH-funded research, to determine the potential utility of cannabidiol for particular anxiety disorders and other disorders, including opioid use disorder. But bottom line is that typically cannabis worsens psychiatric symptoms, especially for individuals vulnerable to or experiencing mood, anxiety, trauma-related or psychotic disorders. Doesn't make it better, it makes it worse. It may feel better in the short run, but then it tends to exacerbate the problems, okay? So if you, and that's true with lots of drugs, right? If you have schizophrenia and you have a lot of negative symptoms and you're sitting in a chair, if you smoke crack, it's going to give you energy and enlighten your mood, but that dopamine stimulation is also going to turn on all your delusions and hallucinations. So it's, you know, not helpful. I told about the developing brain being especially vulnerable, cognitive performance, and increasing the risk for later development of mood and substance use disorders. There is insufficient evidence for the use of medical cannabis to treat any psychiatric disorder, okay? That doesn't mean it doesn't. It just means we don't have the evidence right now. There's anecdotal evidence. There are lots of states that have medical marijuana for PTSD and stuff like that. And maybe in some of those cases it's working. But we don't have good scientific evidence to support it So I don't think it's a great idea. I understand the balance between wanting to relieve suffering, right, and wanting to do like something that's safe, right? And there's probably a balance between the two. But that's a particularly problematic thing, right? Because there's a lot of qualifying conditions of PTSD for medical marijuana. And yet we don't really have very high-grade scientific evidence to support that. And another thing that's problematic is the blood levels of THC and its metabolites don't correspond to physical or mental impairment levels, so it's not reliable for roadside driver safety testing. You know, people can have less than 15 nanograms per mil of delta-9 THC in their bloodstream and be, you know, like really not making smart decisions when they're driving, even though that's often used as a cutoff, or 50 nanograms per mil is used frequently as a cutoff. And in that range there's a widely variant individual responding, all right? So here's trajectory from first use to development of a substance use disorder. And you see here, I mean, this is all the different drugs, classes of drugs of abuse. And you see here, cannabis is this guy right here, this gray one. And you see that essentially in the first year of use, you get about 7.5% of folks develop an actual cannabis use disorder. So if you just think about that in terms of population base, right? With the increase in initiation, with the increase in past month and daily use, we're seeing a concomitant increase and a real effect as the base in the population expands of users that, at least in the first year, 7.5% of that total population of sort of recreational or maybe medical users are going to end up with a use disorder, right? And so that's a problem. I mean, that's a, you know, at a population health level, that's a problem, right? And if you think about it over 23 years, you'll get almost a little over a third of people who are using consistently over time will develop a disorder. Okay, that's pretty, you know, important evidence. And as I said before, there are comorbid factors that really tell a story. So if you have comorbid psychiatric disorders, it will increase what's called the odds ratio, or the risk of converting from recreational whatever use to a use disorder. So if you have major depression, it doubles it. Generalized anxiety disorder, 2.5 times. Panic attacks doubles it. Social anxiety, 2.5 times. If you're agoraphobic, it triples your risk, right? If you're a stimulant user, it triples the risk. If you use benzos, you know, it's almost 4 times. Opioid use disorders, almost 4 times. If you have an alcohol use disorders, it's almost 11 times the risk. So if you have an alcohol use disorder and you're using cannabis, the likelihood compared to the general population is that you're going to have a cannabis use disorder, okay? I mean, that's just, you know, look at that. And then stimulant use, if you're using methamphetamine or cocaine and you smoke cannabis, you know, look at this, 18 times the risk of the general population. So that comorbidity is like a given, right? I mean, it's really, it would be hard to find somebody who wasn't if they have those kinds of problems. So increased risk of other drug and alcohol use disorders, including prescription opioid use. Individuals who use cannabis by age 17 years of age have 2 to 5 times higher odds of other drug use, alcohol dependence, and drug use disorders. And this was demonstrated in a twin study, okay, where one twin started smoking pot before age 17 and the other did not, right? It was a fairly large sample of twins, and those are the rates that you get. So cannabis withdrawal. So this is from the NESARC study that had more than 40,000 people in the United States, 43,000. And these are in-person interviews covering substance use history. 2,600 were frequent cannabis users, meaning 3 or more times a week, right? And from that, they found a subset of people who only used cannabis, meaning that they never binge drank, and they didn't use other drugs more than twice a week, right? And 44% of the full sample and the subset had experienced 2 or more cannabis withdrawal symptoms, okay? A third of the full sample had 3 or more cannabis withdrawal symptoms, right? So this means cannabis withdrawal, just regular folks that are out there using, say, medical or recreational cannabis, have withdrawal symptomatology. Okay, that's meaningful. That means their bodies have adapted to a constant bath of tetrahydrocannabinol, and their brains have adapted to that, and their physiology is adapted to that. So they show tolerance, perhaps, but when it stops, they show withdrawal symptomatology. Okay, and that's something that most people don't recognize. Okay, they came up with the two types of withdrawal, two factors. One factor, weakness, oversleeping, and slowing down psychomotor retardation. The second one was anxiety, restlessness, depressed mood, and sleeplessness, right? And those were the two major factors they found. But both types were associated with significant distress and impairment. Using the substance to relieve or avoid withdrawal symptomatology, which, by the way, is a diagnostic component of a use disorder, right? And also using more cannabis, right, among the cannabis-only users in that subgroup, which again is another slice of the diagnostic criteria. So withdrawal is not a bad proxy. It's not an exact proxy, but it's close to making you think about people who have withdrawal might likely have a use disorder. Okay, and that's a third of people that are using it. So all of this is not out there. People are not talking this way, right? And if people have panic or personality disorders, it was associated with anxiety symptoms across the two samples. There was association in the only cannabis group with a family history of drug problems, with feeling lethargic and weak, and everybody had an association with depressed mood, right? So here's the withdrawal. Here's some of the common symptoms: insomnia. Right, when you smoke pot, then you go into the kitchen and eat all of the, whatever carbohydrate that's in the kitchen. Well, the reverse is true in withdrawal. Your body does exactly the opposite. You lose your appetite. You become anorexic, right? So you lose your appetite, you might lose weight, anxious, irritable, depressed, maybe a little tremulous. And that's typically what we see. Those are some of the most common symptoms, right? But there is a phase you go through, in the first 4 to 7 days without it. You see this kind of stuff. And then for the next, half a week to 2 weeks, you see some other stuff. And then, you get, insomnia is maintained, mild depression, and some anxiety, which is not dissimilar, by the way, to alcohol. Right? After you detoxify somebody from alcohol use disorder and they're no longer showing acute physiologic symptoms of withdrawal, they very frequently have a sleep disorder. So the brain has only a certain number of ways to cope, and this is one of the overreactions when you take the substance away. And again, post-acute withdrawal, it's similar: memory problems, irritability, mild depression, cravings, and lack of motivation. And we also, I'm going to skip this, but we also know that cannabinoids affect the brain functioning, and that may, as I said earlier, lead to incipient schizophrenia or other psychotic disorders. So we know directly that THC in enough concentration is psychotogenic. What we don't know is that relationship ultimately about who will not come back from that and who ends up triggering a psychotic disorder that you can later then make a diagnosis of, that is, even if you don't smoke any more pot, continues on and is debilitating, impairment, needs its own treatment. We also know that cannabis use over time affects cognitive functioning, right? We know it affects memory, we know it affects decisional process. Longitudinal NIH study looked at 1,000 individuals from infancy to adulthood at 5 different times. And up to 38 years, and they did neuropsychological testing at the beginning and then at the end at age 38. And the more you smoke, the greater the decline in IQ. Statistically significant over time. That's a real finding. Okay. Now, is it like 20 points? No, it's like 6 to 8 points, but it's still that's real. Okay, that's loss of function in your brain, and that's likely permanent. And the earlier you start, the larger the decrease. right? So the more you smoke, the larger the decrease, the earlier you start, the earlier the exposure. Remember what I said about that developing brain? There's your answer, okay? So let's talk about synthetic cannabis. These tend to be full CB1 agonists rather than cannabis, which is what's called a partial or a weak agonist at the receptor. They were originally called Spice, 2004. They're marketed with all kinds of nonsense, saying that they're, perfume sachets and, all kinds of, fake labeling, essentially, that, they say not for human consumption on it, blah, blah, blah. And then they're usually on some kind of herb that's had a compound, sprayed on it. But, we had lots of problems in emergency departments, and finally, the DEA put them on Schedule 1, the prohibited sale of some of these moieties in 2011. The problem is the combinatorial chemists who keep getting ahead of it, because it's not just like, it doesn't just look like THC. There's all kinds of weird chemicals and new compounds that fit the cannabinoid receptor, and they keep finding new moieties. And as soon as the federal government goes, no, we can't, you're not allowed to market or use this one anymore, people produce a new one. So it's out there. But fortunately, the public has gotten a bit more aware of the dangers, but younger folks, especially people in the military, folks who are trying to avoid detection, are frequently the folks that use it. So 75% of youth in treatment, for example, have used this to evade drug tests, okay? And, here's the stuff. You can go on NIDA, drug abuse .gov site and look all this stuff up. It's harmful. It makes people crazy psychotic. It can create cardiovascular collapse. It's a dangerous drug. It's completely unregulated. It's not related to anything that we can even relate to as a sort of like a prescription pain med where there's a legitimate use for it and we kind of know the ins and outs of it. So many of these moieties are new and we don't know what kind of untold terrible effects they have. So one of the recommendations that's come out, here's one guideline, for lower risk cannabis use. Meaning if you're going to use, this is a smarter way to approach it. How am I doing on time? I have no sense of that at all. Anybody tell me what time it is? 5 to 10. Okay, thank you. Abstain from using to fully prevent cannabis-related health problems. That's a no-brainer. People who are going to use it are going to ignore that, right? Avoid initiation before 16 years of age. Choose cannabis products with a low THC potency or balanced THC to cannabidiol ratio. As I said before, cannabidiol appears to be mitigating of the more noxious psychoactive effects of cannabis, right? Abstain from using synthetic cannabinoids, right? Favor non-smoking methods of consumption, but caution in dosing of edibles, right? It uses that knowledge I said before about going over the line, right? Avoid deep inhalation practices which may increase the risk of respiratory problems. Avoid daily or near daily cannabis use because of its high association with a use disorder, right? Abstain from driving while impaired from cannabis to prevent motor vehicle accidents. Populations at higher risk adverse effects should refrain, including pregnant women and individuals with a predisposition for or a first-degree family history of psychosis or substance use disorder. Avoid combining the risk behaviors, for example, early initiation and high frequency, because the use could magnify the likelihood of experiencing cannabis-related outcomes, right? So again, that's just logic. So now let's look at using cannabis for medicinal purposes. What's it good for? Is there actually any legitimate use for it? Well, it turns out there is. This is why it's a remarkable plant in a lot of ways, and one of them is that there really is a use for some components found in the marijuana plant, right? So obviously the thing that people use for recreation is delta-9 tetrahydrocannabinol, the primary psychoactive component. But there's also synthetic delta-9 THC called Marinol. It's been around for a long time. It's Schedule 3, and it's, for example, can be prescribed for cancer-related pain. And it's reasonably effective, especially when combined with other anti-pain medications. Nabilone is a synthetic analog also, and that's rather than a natural one, it's a synthetic one. Also Schedule 3. It has less euphoria. It is good for nausea from cancer chemotherapy. Okay, and it stimulates the appetite in people with like cachexia from HIV, for example, or cancer, and as an adjunct analgesic for neuropathic pain. Nabiximols, or Sativex as it's marketed in England, is a combination 1-to-1 of THC and cannabidiol. Cannabidiol that comes in an oral spray, and in 25 countries outside the U.S., it's approved for spasticity, muscular spasticity, due to multiple sclerosis. And it is now being doing clinical trials in the United States to look for an indication. I believe it's in cancer pain. So we'll see what happens with that. And then Epidiolex, which is cannabidiol, which is the non-get-you-high component, right? This is the one that's anxiolytic and relaxing component of the cannabis plant. It was recently approved as Epidiolex for seizures for 2 very rare seizure disorders, Lennox-Gastaut and Dravet syndrome, both which tend to be pediatric onset severe epilepsy conditions that tend to be refractory to other treatments. And so this is now approved and marketed in the United States. So there are, and that's just the tip of the iceberg. There's, like I said, there's 100 other alkaloids and terpenes and other things in cannabis. Each individually may have, medicinal properties that are as yet underexplored and not documented. So this ad hoc committee came back and said, for therapeutic effects, conclusive or substantial therapeutic effects for the treatment of chronic pain in adults, antiemetics in the treatment of chemotherapy-induced nausea and vomiting, improving patient-reported multiple sclerosis spasticity symptoms. So there's really very good and solid evidence for that. There's some evidence of therapeutic effects in improving sleep outcomes in individuals with sleep disturbance that come from COPD, or obstructive sleep apnea, fibromyalgia, chronic pain, and MS, right? So there's decent but not conclusive evidence there. There's weak evidence of increasing appetite and decreased weight loss associated with HIV/AIDS, but there's some. Improving in clinician-measured MS spasticity symptoms. Improving Gilles de la Tourette syndrome symptoms. There's a couple of reports or whatever, but not really firm evidence. Improving anxiety symptoms in social anxiety disorder, cannabidiol. There's a lot of anecdotal stuff on the blogs about this, right? But the science hasn't really been done yet. And so we really don't know the answer to that. It's totally reasonable for the NIH to support somebody doing a clinical trial. Because it could be very useful. And improving symptoms of PTSD, there's one small fair quality trial, hasn't been replicated, and yet many states in their medical marijuana indications now have PTSD as an indication for medical marijuana. So with just one small study, not a lot, not great. There's insufficient evidence of therapeutic effect in all of the, I won't read through it, but in all of these. Okay, all the things that people say, oh, it made my dystonia better, right, or this or that. And, maybe it's true. I don't want to say it's not true. All I'm saying is that there's no evidence, no scientific evidence. Something worked for somebody somewhere all the time, right? In other words, everything has always worked for somebody. That doesn't mean it works for, in general, everybody. Right, so that's the difference between anecdotal level of evidence, where something may actually have worked for them for whatever reason, and something that goes through a randomized, double-blind, placebo-controlled trial in multiple sites, where the contribution of bias of varying kinds doesn't contribute to the outcomes you find. I'm in a position, having been at this for a while, to see lots of medications in development of all stripes, or being used off-label, in pilot studies that have great results that when you do the double-blind placebo-controlled trial don't work, are not different from placebo. That's why we do this. That's why we have to do the science. That's why the FDA relies upon the science, okay? Because we have to protect the public, right? So now let's move to treatment. Okay, so we've used cannabis as a treatment. Now we're going to treat people for cannabis, right? So let me start off for medication treatment of cannabis use disorder, or CUD. There are no medical treatments for cannabis use disorder, period. Okay? We have great evidence-based treatments for alcohol use disorder, great evidence-based treatment for opioid use disorder, right? And in the case of the opioid use disorder, it's the primary treatment without which you recover at your own peril. Okay? I'm not knocking psychosocial intervention, but psychosocial intervention has a good effect size when you look at stimulant use disorder, for which we have no meds, and alcohol use disorder. It's a good evidence base. For opioid use disorder, we don't have that evidence base. After detoxification, psychosocial treatment alone tends to be a very poor predictor of outcome. If you do medical stabilization, you bind that opioid receptor with anything, you know, whether it's an antagonist, a partial agonist like buprenorphine, or a full agonist like methadone, then you can work your recovery. Then you can make use of psychosocial interventions, and the two work together to get people better over time. But we have no meds for cannabis use disorder, okay? Nothing's approved. We're still looking around. 2 studies show some promise. The first one's gabapentin, an anticonvulsant, 1,200 milligrams a day in divided doses in adults over a 12-week trial, showed reductions in cannabis use, and you know, a larger percentage of those that were absent at the end of the trial. Another one is a glutamate modulator that's over the counter called N-acetylcysteine, 1,200 milligrams twice a day for an 8-week study, and that showed benefit in adolescents when they did a follow-up study. This is Kevin Gray at Medical University of South Carolina doing the study in adults. It didn't work. They got a good outcome in the adolescents, so they went and reanalyzed the data in the adult study, and when they looked at the 18-year-olds in the study, they had a positive signal. They did well. So there's something about aging out or brain maturation, we don't know, but it looks like young adults, adolescents do okay with N-acetylcysteine. It may be something that it's worthy of continuing to investigate. It's only one study. It needs to be replicated. We really need to find that out. Similarly to the gabapentin, I know I used it for a patient that I had, I don't know, 12 years ago, who came in with pretty profound cannabis withdrawal, and I loaded him up on gabapentin because it tends to be non-addictive in general, and you don't get any like positive effects from it, and it's not metabolized, so it's very safe. And he did actually very well. So I said, oh, this might be useful. So at least we have one trial that shows it. There's another study showing buspirone up to 60 milligrams a day, which is what you frequently need for people who are anxious, who have alcohol use disorder, over a 12-week trial, showed some efficacy only in the people that completed the treatment. When you looked at what's called the intention to treat population, which is everybody, there wasn't enough signal. And then the logical thing you would think was like of people who have a cannabis use disorder and they show symptoms of withdrawal, well, what if you do a maintenance replacement study, right? Give them THC and let's see what happens, right? I mean, it's logical, right? So that was tried by my colleague Francis Levin at Columbia, and they gave dronabinol, which is a synthetic THC, 20 milligrams twice a day for 8 weeks, and it worked very nicely on the withdrawal symptomatology, as one would expect. You know, when you're drinking and you go into withdrawal and you have another drink, your withdrawal goes away, right? So that's not a big deal. But unfortunately, it had no effect on cannabis use, right? Because you're basically, you know, throwing oil on the fire. So you could stabilize people's withdrawal using a synthetic cannabinoid, which is essentially a proof of concept for cannabis withdrawal, right? You know, you're doing it in a scientific way, demonstrating, yeah, this is the real thing, right? So, but we do have psychosocial treatment. And this is where the money is for treatment of cannabis use disorders. Okay, so let's look at adolescents. There's one study called the Cannabis Youth Treatment Study. They looked at 5 different short-term psychosocial interventions. The group was 15 to 16-year-old, mostly white males in 2 different randomized trials, but it was the same group. And they compared 5-session motivational enhancement therapy and cognitive behavioral therapy that were sort of morphed into one thing versus 12-session MET-CBT versus a family education and therapy intervention. And then the other study was looking at 5-session MET-CBT versus adolescent community reinforcement and multidimensional family therapy. And what they found is that all 5 groups showed significant reductions before and after the psychosocial intervention, basically increasing their days of abstinence from cannabis, percentage of adolescents in stable recovery, meaning that they had no cannabis use documented, no symptoms of use disorder, okay, and were living in the community, not in a rehab, right? And when they did a follow-up analysis looking for the predictors, what they found is one of the strongest predictors, as it is in any psychotherapy, the strength of the therapeutic alliance was a very, very good predictor of outcome. So for those of you that are not social workers and don't live in this domain maybe in terms of psychotherapy, therapeutic alliance is really important. Who you are and how you are with your clients really, really makes a difference beyond being like whether they like you or not, or you get along. It has a beneficial therapeutic effect in terms of retention and treatment and ability to make use of whatever it is that they're supposed to be experiencing in their psychosocial treatment. Let's look at adults. Okay, so there's a very new systematic review that came out. This is a 2016 systematic review of all of the extant published literature in terms of research on psychosocial interventions for cannabis use disorders in adults, okay? And when they did the high level of abstraction, they found 7 main intervention types: CBT, motivational intervention, combination of MET and CBT, contingency management, which is a reinforcement protocol, right? Vouchers and stuff like that, social support, mindfulness-based meditation, and drug education and counseling. And when they looked at the whole cohort compared to, you know, and these are studies that had one of these things compared to a minimal treatment intervention, something that had attention but no active ingredients of psychosocial therapy, like, you know, like go read this pamphlet on that and stuff like that and have a discussion. They durably reduced the frequency of use and dependent severity at 30-day follow-up. People who got any of these were twice as likely to be abstinent at 30 days than inactive controls. And people who received more than 4 sessions of treatment were 3 times more likely to demonstrate a difference in 30-day abstinence. So dosage of psychosocial intervention makes a difference. You know, managed care companies want you to like see them once or twice and then see them in 2 months, right? That's not proper treatment. Treatment requires dosage, and that dosage is psychosocial treatment exposure, right? And the easiest way we can dose it is by number of sessions. So they broke it down and they say, you know, you need 5 or more sessions to have that quality that's going to make a difference, right? Intensive intervention, meaning over 5 or more sessions based on the combination of motivational enhancement treatment. Is everybody familiar with that particular treatment? Most of you probably are aware of MI, of motivational interviewing. But MET was a very specific intervention that was developed during the Cocaine Collaborative study by NIDA. And so if you don't know what MET is in particular, it's manualized. You can download it from the NIDA website. And it's a evidence-based treatment that uses components of motivational interviewing and stages of change stuff to help people decide to move forward with their recovery. So that intensive intervention that included both MET and CBT with abstinence-based incentives, meaning it had an element of contingency management. So in other words, you hand in a urine and that urine demonstrates no cannabinoids in it, then you can put your hand in a fishbowl and pull out a prize, usually of minor value. But that reinforcement has a very powerful, all the literature on CM shows it has a very, very powerful incentive for that person to maintain their abstinence. It works really well, and it's not very costly because you don't have to give big prizes. Okay, it's just that little something seems to really add another dimension to motivation. Okay, 6 studies which added the adjunctive contingency management suggested improvements in cannabis use frequency and severity of dependence when combined with the CBT alone or with MET and CBT. Abstinence rates were relatively low and unstable, but comparable to other treatments for substance use disorders. At follow-up of longer than 4 months, overall they had about 23% past month abstinence, but it was 12% in the controls. So it doubled what you find in the controls, right? It's not a home run, but it's something, and it's real and it's effective, right? So to me, that's hard news that, you know, we have to do better, we have to try harder. Substance use disorders are tough and intractable, but we can make a difference, right? So what are the policy implications? I've run through a lot of stuff today. I don't see too many eyes rolling, so that's good. So here's legality by state as of now. Remember, cannabis under federal law is still a Schedule I substance. It is illegal, right? And it's the states that have basically, under the Obama administration, given essentially the license to do their own thing with a hold harmless from the federal government. 10 states plus District of Columbia, Northern Marijuana Islands, did you hear that? Mariana Islands and Guam have legalized recreational in addition to medicinal cannabis. And I'll bet you that Marianas and Guam have increased tourism now. You laugh, but I'll bet you it's true. And I'll bet you it's going to do something for their bottom line in terms of the tourist industry, right? And 33 states have medicinal cannabis. You can see sort of what's happening here. And as I said earlier, you know, and Rob Kent's going to talk about it, but, you know, New York State's been, you know, kind of struggling with, you know, okay, we have medicinal cannabis, but do we legalize it? And if so, how do we do that, right? How do we get there, right? Given everything I've already said, right? And I'm sure the legislators don't know all of these data, okay? I mean, they know some, and some of the ones on the health committee probably know more, but, so here's from the Obstetrics and Gynecology Academy. This is their policy for pregnancy and lactation, 2015. They know it's the most commonly used illicit drug during pregnancy. For some reason, women think it's safe, especially if it's legal. Well, it should be okay. And we know alcohol's bad for baby's development, but they don't have the news on that. So use ranges from 2 to 5%. You want to encourage pregnant women or those contemplating pregnancy to discontinue their cannabis use due to concerns regarding impaired neurodevelopment of the fetus, right? And maternal and fetal exposure to adverse effects of smoking, if that's the way they're using it. Discourage OBGYNs for prescribing or suggesting the use of cannabis for medicinal purposes. Okay, I chaired the American Psychiatric Association policy statement on medical marijuana. And briefly, what we came up with is all the other drugs that docs prescribe have gone through a rigorous FDA approval process. Doctors should not be being put in the position of having some kind of drug that's going to have some kind of properties that has a set of harms associated with it, that's not regulated, we don't know the strength, has multiple routes of administration, it's under the user's desire, essentially, about how much or how little they take in. We should not be being put in a position of having to prescribe that. If you want to legalize it, that's a cultural decision. You know, whether it's legal or not, that's a higher pay grade. That's a national conversation or a state conversation about legality and access to something that you want to do, okay? That's not medical. You know, we can inform about harms and all the stuff I've done today. But doctors should not be being put in a position to do a prescription for something they have no control of, have no idea about the strength, quality, purity, blah, 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 okay? Obviously, no medical marijuana during preconception, pregnancy, and lactation. And you want to use alternative therapies for whatever that is that you're using it for that have better pregnancy-specific safety data. And there's insufficient data on the effects of cannabis use on infants during lactation and breastfeeding, so discourage marijuana use, which is what the FDA does in its indication when it makes stuff that's contraindicated or relatively contraindicated in pregnancy. It doesn't mean that it's dangerous in pregnancy. It means it hasn't been examined in terms of scientific evidence, and without that evidence, you don't want to introduce something that might be potentially dangerous to the mother or her unborn child, right? So you put in a contraindication. You know, above all, do no harm, or first do no harm. So we have a work group at the American Academy of Addiction Psychiatry. I chair public policy, and we worked with another group, which was a cannabis special interest group. And over the last several months, we've developed a model policy for states that are thinking about legalizing cannabis. And what we try to do is bring all of our knowledge and concerns into this model law, essentially, model regulatory position. So, if you're going to make it legal, you limit recreational cannabis to adults over 21, if not 24. Remember what I said about the developing brain? 20-year-olds and 21-year-olds probably still shouldn't be smoking pot. You know, they should really wait until they're in their mid-20s, and then they may be in a much better risk category, so to speak. Also, as I said earlier, the earlier the exposure, the higher the risk for all the brain stuff and also use disorder risk. And the later you start, and that's true with pretty much most drugs, the later you start, the more mature you are and the more judgment you can exercise over that use. And in general, the net relative risk is lower. Okay? States not to include mental disorders such as PTSD, anxiety, depression, opioid use disorder as qualifying conditions, as there is no psychiatric indication for medical cannabis. None. Advertising for cannabis for treating mental disorders is banned. Okay? It's bad enough that you turn on your TV and you're bombarded with all of these pharmaceutical advertisements. Other countries don't allow that, by the way. Regulation appropriates oops, go back. Regulation appropriates funds to purchase high-grade analytic equipment critical for quality control measures that ensure proper chain of custody, testing, and labeling of cannabis-derived products so that users have accurate information about what they're using, right? So it's at least one idea about being able to have, you know, just like when you buy your cereal and you look at the labeling on the side, it's got all the ingredients and it's got it broken down by fats, carbohydrates, and proteins, and the caloric load and the amount of soluble and insoluble fiber and all the rest of it. We need you know, truth in you know, what people are selling, okay? Legislation requires mechanisms to audit and impose penalties for infractions or fraudulent practices. Any legal expansion of cannabis use includes strategic public awareness campaigns and packaging alerts about potential harms from use, especially heavy or daily use, or of high-potency products such as risks of addiction, psychosis, which is increased with edibles, as I said earlier, and worsening of mood and anxiety symptoms. Advertising campaigns are enacted to prevent cannabis use during pregnancy and breastfeeding. Regulations are made to guard against impaired driving and innovative approaches to respond to this vital public safety issue, right? Because we're seeing more of that in Colorado and California, right? And you know, I'm getting feedback from from docs in those states about the cost of the emergency room trauma visits and freakouts that are starting to erode the tax additions of commercialized cannabis. Right? States maintain a public registry annually reporting on all adverse outcomes associated with medical and recreational cannabis product sales and consumption. And I won't go through this, but basically we need to do a whole lot more research You know, we were prohibited for many decades. The quality of cannabis that was available for research, for the lucky few that the federal government allowed to do the research, was poor quality and didn't look or act anything like the cannabis that's available today. And so we need to do more and better research so that we can be more scientifically informed about the evidence for and against cannabis. Thank you very much.